I'm Dr Bellmunt. I'm a GU medical oncologist, associate professor at Harvard Medical School, and mainly treating bladder cancer patients here at the GU Lung Center. Regarding the mechanism of action of pembrolizumab, the pembrolizumab is one of these new medications named checkpoint inhibitors. Those are monoclonal antibodies that are blocking the checkpoints that are interacting in between the tumor cells and the immune cells. We know that the tumor cells, in order to prevent that the immune cells attack the tumor cells, they develop some mechanisms like brakes that are preventing the lymphocytes to kill the tumor cells. What we are doing with these new monoclonal antibodies is like releasing these brakes that will allow the immune cells that are surrounding the tumor to attack the tumor cell and to kill the tumor cell. So the study, the keynote, named the Keynote 45, is a trial that was designed trying to improve the outcome in patients with advanced bladder cancer who have failed first-line chemotherapy with platinum-based regimes. So this trial included 540 patients that were randomized either to receive the pembrolizumab given every 3 weeks IV, or to receive what was considered to be the standard of care, that is the chemotherapy. And the chemotherapy could be either docetaxel, paclitaxel, or vinflunine in Europe, because vinflunine is the only drug approved in second line and is only approved in Europe and not in the US. So the main endpoint of this trial was overall survival. So really, this was a strong endpoint because until now, no drug did show any survival advantage in this second-line setting of advanced bladder cancer patients. This trial was a one-to-one randomization, and the main goal was looking for a reduction in 22% in the risk of death. And this is what it was required to have 470 events. In fact, the trial was designed with 2 different interim analyses before the final analysis, and at the second interim analysis that happened on September the 7th, so the main endpoint was achieved. So there was a statistically significant survival benefit for pembrolizumab compared to chemotherapy. And obviously this is a landmark trial because for the first time in second line, the role of immunotherapy is being demonstrated, beating the chemotherapy in that space. So in terms of other characteristics and benefits that have been seen in this trial is, in addition to observing this, in fact, it's a 27% reduction in the risk of death. We have seen that the pembrolizumab drug produced up to a double of the responses, the objective responses seen compared with chemotherapy. It was 21% versus 11%. But the most important thing is that these responses are high-quality responses. That means that some selected patients, although it's only 20%, but some selected patients of these responding patients have long-lasting responses. We cannot say about cure, but what we can say is that at the time of the analysis of this trial, the median duration of responses has not been reached. Although for chemotherapy, the median duration of responses has been 4.5 months. That means you see responses with chemotherapy, but these responses are quite limited, and after 5 months, the tumor starts growing again. With immunotherapy, one of the main benefits is that some selected patients we see high-quality responses, meaning that some patients respond to therapy and then don't recur again. So in addition to observing this benefit in survival, in response rate, and in the quality of responses, obviously tolerability in the second-line setting is crucial. And the comparison we saw is that the side effects seen were 60% for immunotherapy compared to 90% with chemotherapy. In addition, some quality of life analysis was done, and this was presented recently at this recent ASCO GU, and the quality of life did show a substantial benefit in patients receiving immunotherapy, meaning that pembrolizumab is not only prolonging the life expectancy of the patients, but in addition is with less side effects and improving the quality of life of our patients. So there is a lot of information and controversies about the potential receptor of this drug, or the potential biomarker for these checkpoint inhibitors. So the PD-1 inhibitors like pembrolizumab, initially they need to find this PDL that is the ligand. So a lot of studies looking for the correlation between the expression of the PD-L1 and responses have been made. And in fact, in that study, what we saw is that the benefit was seen independent of the PD-L1 expression. However, what we saw, there was a sub-analysis that was what was called the composite positive score, assuming that patients having more than 10% PD-L1 positivity were going to have higher responses. In fact, we didn't see that, but what we saw here, this was against what was expected, patients having high PD-L1 staining, the prognosis was much more poor, because even that the benefit was seen with immunotherapy, the median survival in patients having more than 10% PD-L1 positivity was less. The median survival for the whole patient population was 10.3 months, and this beat the survival of chemotherapy that was 7.4 months. But in this subgroup of PD-L1 positive patients, the median survival was 8 months versus 5 months. So still, the immunotherapy beat chemotherapy. However, the median survival was less. And this was really an unexpected finding. Well, obviously, what we have seen here is that there is a benefit in its selected patient populations, only these 20% patients responding, and a small percentage of these patients are going to have prolonged benefit. And obviously, we need to build on these achievements, and the way that the research is moving forward is in the field of combinations. We have, in addition of these PD-1, PD-L1 inhibitors, we have now other checkpoint inhibitors. So we know that all these checks of the immune system, there is not only the PD-1, PD-L1, there are several others, and drugs that are targeting other of these checkpoint inhibitors are now being studied in combination. Also, we are now not trying to forget the role of chemotherapy, because chemotherapy still might play a role, but we are trying to see if combining in an adequate way, meaning giving first chemotherapy to release new antigens and then give an immune checkpoint inhibitor might be of benefit. So there are now a lot of studies also in different settings, in different stages of blood cancer, exploring the role of combinations, and the combinations could be with other immune checkpoint inhibitors, it could be with chemotherapy, or it could be with targeted agents. Here at Dana Farber, for example, we have an ongoing trial that is combining Pembrolizumab with a monoclonal antibody against FGFR3, because we know that FGFR3 is a target for therapeutic intervention, meaning that if we combine these two agents, we are going to improve the results that we have seen nowadays with the phase 3 Pembrolizumab. Well, bladder cancer has been a bit a forgotten disease, a disease that we have not seen any substantial advances since the last 20 years. 20 years ago, a combination chemotherapy named MBAC was established as a standard of care, and several randomized phase 3 clinical trials have been developed comparing the MBAC with platinum gemcitabine, with triple regimens, adding some targeted agents, and there has been no improvement in first line. But the thing has been even worse in second line, because as mentioned, there has not been any drug approved in second line. We have been using chemotherapy, taxanes, paclitaxel, docetaxel in second line. But now I think that we have a bright light and a good hopes for our patients, because with the checkpoint inhibitors, Pembrolizumab or others that are already available for the patients, like atezolizumab or nivolumab, we see a better outcome from our patients in second line, and obviously moving to first line, we hope to obviously improve the patient outcomes.